My name's Kate Shepherd and I'm going to tell you about a study that was conducted as part of my MSc in Palliative Care at King's College London. The research was a pilot study to explore the feasibility and acceptability of the kidney care plan in patients with chronic kidney disease who are being managed conservatively without renal replacement therapy. The number of elderly people with chronic kidney disease, stage 5, is steadily rising. Many of those have multiple comorbidities for whom dialysis may not provide a survival advantage. Therefore, an increasing number of patients are being managed conservatively without dialysis and requiring supportive and palliative care. The UK National End-of-Life Care Strategy, published in 2008, suggests that all people approaching the end of life need to have their needs assessed, their wishes and preferences discussed, and an agreed set of actions reflecting the choices they make about their care recorded in a care plan. In 2010, NHS Kidney Care introduced the Kidney Care Plan. The aim is that all patients with chronic kidney disease are given a personal folder designed to organise support around their individual needs. It contains prompts for discussion with a specialist nurse or another member of the kidney team on various subjects and includes a section for keeping notes. The Kidney Care Plan focuses on outcomes, goals or information needs that the patients themselves identify as their priority. Over the years, there has been a shift in the definition of advanced care plans to focus much more on patient-centred goals, wishes and preferences. So there are clear similarities with the Kidney Care Plan and advanced care plans given the intended purpose of the Kidney Care Plan. We conducted a qualitative study using semi-structured interviews of patients who are receiving conservative management of their kidney disease. We wanted to explore what aspects of the Kidney Care Plan were important to patients and why, to identify what issues are important to patients but not already included in the care plan, and to make recommendations on the use and the future content of the Kidney Care Plan. All interviews were conducted in the participant's own home and lasted between 40 and 60 minutes. All of the participants had made the decision to follow the conservative care pathway, and they were recruited from the renal unit at King's College NHS Foundation Trust, which serves an inner-city population of 700,000 in the London boroughs of Lambeth, Southwark and Lewisham. A topic guide was developed to guide the interviews to allow key areas to be explored, but also allowed participants the opportunity to share additional information they felt to be important. Examples of some of the questions relating to the Kidney Care Plan were: what factors do you think are important within the care plan and why? What factors do you think are not important within the care plan? And what additional factors do you think should be included in the care plan and why? The topic guide was tested with 2 patients in a clinical consultation to ensure that the questions and areas to be covered were relevant and made sense. The framework analysis method was used to organise the data from the interviews and to identify emerging themes. I was the only researcher who coded the data in this study, although having a selection of the interview transcripts validated by my academic supervisor increased credibility. Where coding differed, areas were reconsidered until agreement was finally achieved. In an attempt to preserve anonymity, we've changed the names of all study participants. The topic guide included demographic details, disease history, understanding of their illness, the impact chronic kidney disease and other illnesses had on them and their family, and the Kidney Care Plan. This was a small sample and there were 8 participants in total, with ages ranging from 79 to 92 years. We attempted to recruit as diverse a sample as possible. I want to highlight here that these participants were clearly very unwell, and this is demonstrated by the low EGFRs. As you can see, Jobel had an EGFR of 7 and Donald had an EGFR of just 5. 4 of the participants died a short period after being interviewed, and we think this demonstrates that it is in fact acceptable and feasible to interview participants close to death. These are the themes that are already suggested in the Kidney Care Plan as potential topics for discussion. Although there was broad agreement about the overall content of the existing Kidney Care Plan, patient participants identified additional themes that were also considered central to the patient and family experience. As you can see, the additional topics most participants thought were important comprised a focus on illness progression, approaching end-of-life discussions, and wishes and preferences. These themes are all themes that are not already included and participants would like to be included in the Kidney Care Plan. All 8 participants thought wishes and preferences should be included in the kidney care plan in some capacity. Some thought it would be difficult to spontaneously open these conversations with their family and/or their kidney team and feel this topic is often ignored. So having it included in the kidney care plan would prompt discussions like this and ensure they were given the opportunity to discuss these issues. There was the belief that the kidney care plan would allow a safe discussion of these sensitive and potentially upsetting topics. Cedric, a 92-year-old white British gentleman with an 𝐒𝐓𝐷 of 13 and who died 5 months after being interviewed, said, "I mean, the way I see it, it's going to happen, so why pretend that it isn't? It's best to make plans and discuss these things before the big event, isn't it?" All 8 participants thought end-of-life discussions should be included within the kidney care plan. Most participants had not had end-of-life discussions with their family or members of their healthcare team. However, they all believed they would welcome the opportunity to have these discussions if there was an appropriate platform to do this. Valerie, an 80-year-old white British lady with an 𝐒𝐓𝐷 of 9 who died 3 months after being interviewed, said, "I mean, we all know I'm getting worse and will only get more so as time goes on. My family don't like to discuss things like that. If I ever bring up the issue of when I die, they just change the subject and tell me not to be silly and try and make a joke out of it. But I think it's important for everyone to talk about." 8 participants suggested there should be a section to discuss deterioration in health. What is likely to happen as kidney function and therefore general health deteriorates was a theme that was mentioned by all participants. Although they each had varying levels of understanding of kidney disease, they all had a notion that things would get worse without the initiation of dialysis. Knowing what is likely to happen gave a sense of control over the illness. Donald, a 79-year-old black Caribbean gentleman with an 𝐒𝐓𝐷 of just 5 who died 2 months after being interviewed, said, "It's not something that normally gets brought up, you know. In clinic, it's more about the pressure and the blood test and things. Because things will get worse, won't they? So it's good to have an idea about what is likely to happen." Another participant, Jenny, an 87-year-old white British lady with an 𝐒𝐓𝐷 of 10, said, "It's not something you think about every day, is it? I don't think anybody likes to think about getting worse, do they? But it is important to know what to expect." Cedric agreed and said, "I know you can't tell me how long I've got left to live, but an explanation about the things that might happen as things get worse would help." Some of the participants were not aware that they could have a say in place of care or death, and they welcomed the chance to discuss these options. Jobel, an 86-year-old black Caribbean gentleman with an 𝐒𝐓𝐷 of only 7 who died a month after being interviewed, illustrated this and said, "I don't really have concerns as such, but I don't want to be on my own, because I wouldn't just bring that up, say, in a clinic. So yes, having a specific section on dying and where you might die would help, and then that way people would know." This is the first qualitative study to explore the acceptability and feasibility of the kidney care plan in this population. We explored potential amendments to an existing document to try and improve quality of life from the participants' perspective. We interviewed participants who were very unwell, some of whom were very close to death at the time of interview, and this indicates that it is acceptable and feasible to interview patients this close to death. The cross-sectional design of the study didn't allow for exploration of what participants felt about the kidney care plan over time and how these may relate to how they understood and lived with their advanced kidney disease, and how their views might have changed with worsening kidney function. A potential source of bias was that I was familiar with many of the patients following the conservative care pathway, given the clinical nature of my role at the time. Despite efforts to minimise this, there remained preconceptions from both parties. Participants assumed I had in-depth knowledge of the conservative care pathway. In addition, I already felt aware of some of the issues important to this population regarding conservative management of their disease. The kidney care plan is a useful document, and this pilot study has confirmed this. It received positive feedback, but we need to be mindful that for an illness as complex as kidney disease, affecting a widely diverse population, a care plan of this nature can never be one size fits all. It must be carefully tailored to meet individual needs, reviewed and evaluated to meet the changing and often complex needs of the conservatively managed kidney patient. We explored the feasibility and acceptability of interviewing patients with advanced kidney disease and identified where potential changes need to be made. We now need to pilot the kidney care plan with the amendments more extensively to see if these really are the issues that this patient population feel to be important and should be included to improve the patient and family experience. The UK End-of-Life Care Strategy supports these important findings. We recommend that the document continues to be developed to better meet the needs of this patient group, and that communication, training and skills accompany its implementation to best facilitate favourable patient and family outcomes.